Hello and welcome to the Fit to Transform podcast, where you learn how to train and diet effectively and, most importantly, how to maintain those results for life, once and for all. I'm Nikias Tomasiello, a transgender training and nutrition coach working online with anyone who's ready for a true lifestyle transformation, anywhere they may be in the world. As a friendly reminder, any and all information provided is for educational purposes only. You should consult with your doctor before implementing any changes to your diet and exercise program. With that disclaimer out of the way, thank you for being here. Now grab yourself a cup of tea or pre-workouts and enjoy.
Yo, dear listeners, welcome back to the podcast. Today, I'm sitting together with Dr. Christle Guevarra. And now that I'm thinking about it, I should have asked you how to say your last name, Christle, before we started.
You said it perfectly. You said it better than I say it. I say it with an American accent, so.
It helps that I'm Italian, so anything Spanish I can make sound somewhat correct.
I love it.
In any case, I'm having you on the podcast today because I want to talk about these weight loss drugs that lately have become really popular. I don't want to call them new because I'm aware that they've been around a long time, but they have really come to the fore in the last couple of years. And I've never had a podcast where I could delve deeply into it.
Yeah.
So now that I have you here, I'm going to break the ice with the typical question I ask all of my new guests so that my listeners can get to know you a little bit better. And that is, who are you? What do you do? And why are you so awesome at it?
Oh, geez. Oh gosh, already I'm like, oh, what's going on? Yeah, I guess you can start from most recent. I currently run I'm part of the RP YouTube department. So Dr. Mike channel, Renaissance Periodization. I've been working with them formally for the last, I would say, 3 years. I actually wanted to get a change of pace out of medicine because I felt very burnt out. Because I was in the COVID pandemic. I was, a resident physician. I did the last half of my training in the middle of the pandemic, and so I really just wanted a change of pace. So I started working at RP in the marketing department as an intern. I did some marketing research, and then did a couple of other different projects here and there, and ended up finding myself, in the YouTube department, just really organizing everything, just making sure there was a process, doing all the back end operations, scheduling all the collaborations, making sure that, things ran smoothly. So that's what I've been doing for the last year or so. Um, I do have one more project that's coming up, which is RPU, which is our learning platform that's going to be coming out this year. I've been also working on that as well, kind of in my downtime or my free time. And so those are and then I also run a private telemedicine practice on the side. So bunch of different hats. I think just being able to learn quickly on your feet, being able to pivot when necessary, and then always just looking for feedback, I think is the big things that, staying sort of awesome at what you do, being open and receptive to feedback, and then just keep on, learning from your mistakes is how I, approach everything, regardless of, what field I end up diving into.
You are really busy with a variety of different occupations that are quite eclectic overall. What do you like about each of them, especially?
Um, I really so for medicine, I wanted to manage people's health. Um, I liked, I chose family medicine and sports medicine because I liked having that mix of, um, being able to see a, person with diabetes, or seeing a kid who's completely healthy, or an adult who, lifts weights, and, sort of the, typical kind of person who would find the RP channel. I liked having that variety, and I always liked being on my toes. The things that I really like about RP is the team. Everybody is really, diligent, hardworking, really here to kind of support each other. But we also really love our work, and I think that sort of is kind of, there's a lot of defining factors that I've noticed with people at RP, but I think they really just love what they do. And that in turn, makes me really excited to get to work and also be able to contribute because I love the work, but I also get to love the people that I, enjoy that work with. So I think that is the best part of, working at RP. And um, I'm not, a shill salesperson. I could, so I also like the fact that we're all pretty honest people and I have trouble lying. So, the fact that we, put out no BS kind of information and we're not trying to sell people like ridiculous supplements is also a huge bonus.
Oh, yes, I bet it's one of the big reasons why I've always appreciated RP's work and I've been following you and the team for so many years. And I think, thank you for sharing that, by the way. The reason I asked is that I really wanted to give the audience a good understanding of why you're the perfect person to talk about this, because you help other people with aspects of their health, like these drugs, for example. You have your own personal experience with them. And clearly, you are very committed to honest, evidence based, and practical information that people can apply in their own lives. So that's why I have you here today. And my first question then would be, what are these drugs? What names are they known by so that everybody is on the same page? And what it is that they do exactly?
Yeah. The so I guess let's start most recent and then kind of work our way down. So the most recent one is terzapatide, which is that is the generic word. And then the oh my gosh, Zepbound would be one of the trade names for it. Um, and so that is a dual agonist medication. So it not only affects the GLP-1 receptor, but also affects the GIP receptor as well. Should we just go through the names first and then kind of talk about the?
Yes, I think that makes sense.
Okay. Um, Semaglutide, semaglutide. I've heard it both ways. I've heard semaglutide on the commercials that come out in the United States. It's fine. Tomato, tomato. We all know what people are talking about. Wegovy is maybe a brand name that people have heard of. Also, Ozempic has been kind of thrown around. They've been used interchangeably. It's fine. Um, and also, Ribelsis is the oral tab version of semaglutide. So the other one that I just wanted to point out that exists is liraglutide or Saxenda. That was the very first GLP-1 agonist that was FDA approved here in the United States for weight management, and that was back in 2014. I think that covers all of the names. And then what they do is that they affect, one of two receptors. So the GLP-1 receptor is responsible for a couple of different things, right? So the GLP-1 receptor is responsible for insulin secretion. So when we ingest, food, we have receptors in our intestines that sort of signal out, hey, we're getting, this nice bolus of food, this bolus of nutrients. We need, the pancreas to make some insulin so we can utilize that glucose, shuttle it off to, our brains, shuttle it off to our liver, shuttle it off to our muscles. And, once that happens, it does its thing. The problem with the GLP-1, with GLP-1s and the receptors is that GLP-1, the half-life of GLP-1 is somewhere on the order of 3 to 5 minutes. So it's not very long at all. And so by using these drugs, they interact with the GLP-1 receptors, but the half-life is much, much longer than 3 to 5 minutes. So you have all sorts of, you have glucose control, and also additionally, you have receptors in your brain that also mark satiety and fullness. And the last thing that the GLP-1 is also important with affecting is uh, the stomach. movements in the stomach. And so it does slow down digestion. So between the receptors in your brain and also the slowing down of digestion, people feel that sense of satiety and fullness, which causes them to eat less, or they get fuller quicker. They can, kind of put down the fork a little bit sooner. So that's, pretty much the main effects of GLP-1. The dual agonist portion of that, the thing that's really important about something like tirzepatide is it also sort of decreases acid production in the stomach, um, which plays into a lot of this, undesirable, annoying side effects that people do experience on these drugs, such as nausea, such as heartburn. It seems that a lot of people seem to tolerate the side effect profile for tirzepatide seems to be a lot more favorable in comparison to semaglutide.
Would you mind explaining what GLP-1 is in simple terms and how the relationship between it and the receptors work, just in case somebody
Yeah.
doesn't know what a receptor may be?
Yeah, sorry. I was like trying to explain it and then I told a story and I kind of went out. So GLP-1 is a hormone that is produced. That is so the GLP-1 and glucagon like peptide 1 and gastric inhibitory peptide are just two hormones that are made in our bodies. And they interact with they use chemical signals. So it is a chemical signal that travels through our bloodstream and then it lands on a receptor which is on, various parts of our body. So in this case, our pancreas. The hormone comes along and interacts with the pancreas and it tells it, hey, make some insulin for me. Um, I need you to do this. The pancreas then makes some insulin and a whole host of other functions. And then after a while, um, there is a different enzyme that comes in to actually deactivate this hormone. It actually it's the DP. It's a particular enzyme that comes in, and it's like, you know what, GLP-1, we're done. We're done here making, making insulin. I'm going to recycle you now, and I'm going to get rid of you. So that's basically why the GLP-1 hormone does not last very long. There is an enzyme that also comes in to sort of destroy it and deactivate it. So I hope that sort of clarifies things.
Yes, it does. Thank you very much. So clearly, especially the GLP-1 aspect of the drugs can have very potent effects on somebody's ability to manage their weight and to on effects on their relationship with food. Now, based on the evidence that we have available, how effective are these weight loss drugs?
Oh gosh, based off of the studies, pretty dang effective. Honestly think it was a combination of the clinical trials that semaglutide had gone through, as well as the clinical trials that tirzepatide had gone through, plus social media that has really sort of, overwhelmingly made these drugs so popular because these drugs have been around not just for diabetes, but also for weight management for a while. But the amount of weight loss that people had lost, you're looking at somewhere along the average of, 20% weight loss. So from your starting weight, and they were able to show that it increased. It was a very dose, dependent curve. So like the more higher the doses, the more weight loss, people have experienced. I think one of the for semaglutide, it was, I mean, almost 85% of people had at least lost 5% of their starting weight, and that's in combination with. I know that they had done some nutrition. They did do some stuff with nutrition. They did encourage exercise, regularly. So it was, I guess when you take a look at it from a clinical trial standpoint, they did give nod to the fact that this, medication is really to be used in conjunction with lifestyle interventions. So, but I mean, yeah, you're looking at, 20% weight loss. That's pretty dang cool. And at the very least, you're almost guaranteed to get 5%, weight loss out of it. I mean, that, huge advantage in my opinion.
So, just to make sure that everybody understands, you and I are aware of the importance of losing even 5% of your body weight. But some people might hear that and think, oh, 5%, that's really not much. So, how valuable would it be to have guaranteed success at losing at least 5%?
I mean, that's a great question. You also have to keep in mind that, and I tend to always sort of forget to put this in perspective, is um, you and us being in sort of the evidence based fitness space is a very small, like, cohort subset of the population. Like, I know it seems like a lot sometimes because you look at social media and people are pinging you left and right, posts are happening. But when you think about the rest of the general population, I mean, people who are their BMIs are 40, 50, 60, man, the complications that can come along with a BMI in that territory. And I understand that we're not just talking about people who have a lot of muscle and maybe a little bit, fat. Like, I understand that. Believe me, I'm very well aware of that. I'm still in the overweight category at a BMI of 28.5, and my body fat on a DEXA is in the low 20, somewhere between 20, 20-ish percent. So I get it. But the majority of people, at least in the United States, I mean, 5% would just make such a huge difference in, you know, um, not just with, physique changes, but like high blood pressure. We're thinking about diabetes, and all the complications that can come along with that.
In fact, I'm not exactly sure if that's the same in America, but in the UK, where I'm based, the NHS, the National Health System, and the doctors that work for it will typically recommend to try to lose and maintain 5 to 10%, even if you never lose any more weight than that, because it's scientifically proven to have such strong beneficial effects on your health.
Yes, yes. I would say that that's pretty much the similar sentiment here in the United States as well.
Very interesting. So now you said that it's almost guaranteed to lose at least 5% of your body weight. I was wondering if the 20%, I think you said up to 20%. So
Mhm.
that's not the average loss. It's more like the utmost that you could get as one person, as an individual, rather than the average across all studies.
Yes, yes, because I mean, they had to separate them into different dosing categories and stuff like that. So I'm not sure about what the average is for even just the population right now. Um, so
That makes sense. I just wanted to make sure that I understood correctly. So, are any of the studies that have been conducted so far, do they include specific differentiations in fat mass and lean body mass loss, or do they only study the total body mass loss?
that is a really great question. When I did my last deep dive, I had not seen the I want to say they are in the works. The last time I had done a deep dive, I had not located that because I know that that is a huge thing to consider. I know that a lot of the older trials that I had looked at for semaglutide, and tirzepatide did not. It only focused on the weight, and unfortunately, that is a huge distinction the really great point that you brought up, and I feel like that is I'm still, even with my own colleagues, my own physician colleagues, I still like find myself having to have that conversation and bring up that point about body composition and making sure that we're maintaining lean muscle mass. It's getting better with time. I'm noticing on social media, but it still sometimes baffles me that we're still having these conversations. But it's good. It's a good thing, but I still do see it people focusing on just the scale number and not body comp.
Yes, I bring this up because my most loyal listeners will know that it's very important to maintain as much muscle mass as we can, and that the faster the weight loss occurs, the more at risk of lean body mass loss, or like, which includes muscle mass. The more at risk you may be of losing lean body mass, which may also include muscle mass. Saying that, that brings up another question actually. When we're talking about the amount of weight loss that you can achieve, what is the time scale in these studies?
Oh gosh, I think the time scale in those studies was over a year. 72 weeks. I've seen like 60 something, 68 weeks, 72 weeks. These had been looked at, over very long periods of time. Um, so, well, 52 weeks in a year. So yes, well over a year. Um,
So if we say 72, because it's easy math, that's a year plus 5 months. So it's about 17 months.
yeah,
So we're talking a little over 1% of your weight, of your starting body weight per month or so.
yeah, yeah, yeah. I would say so. The Yeah, the I do have, you do bring up a great point, and another kind of not like another thing that I just feel like sort of gets lost, at least with from the medicine side to the sort of um fitness space side is, I as somebody who is in the fitness space, I look at these studies, I look at the amount of weight loss, and I think, have they been just dieting down for that long? Have they been in a deficit for that long? How, you know, do they run into the same like diet fatigue or training fatigue? I do have a client or patient that actually came to me because they had been sort of, you know, uh, dieting themselves into the grave, and they were still very early on in their journey. They had just had bariatric surgery and were given a meal plan by a licensed nutritionist, and was just kind of like, I'm not sure what to do, I'm really exhausted. And then we take a look at what's actually going on, or what's actually being consumed, and it's very little. And so I think the another point that we really need to think about is like, you know are we, when are we going to take breaks from actually doing the caloric deficit? Can we get them to a place where we can increase their calories, get them stabilized before going on another amount of set of fat loss or weight loss or whatever you want to call it?
That's exactly why I was trying to math this out over a shorter term than 72 weeks. Because if I think losing 1% of your body weight per month, well, typically for somebody who's resistance training and eating a high protein diet, we would be easily considering zero point 0.5 to 1% body weight loss, even on a weekly basis. So that's already reassuring to me in that, okay, if we're extending the timeline to 4 weeks instead of one, the risk of lean body mass loss may be lower. It may also imply that the people in these studies are also taking breaks, which then can give some reassurance to potential consumers of these drugs that you don't need to be in diet mode for 72 weeks to get these kind of results, because as you brought up, diet fatigue can be a very real issue. And that's actually a good segue into another question that I was going to ask you, which is, you brought up short term digestive issues that can be a side effect. And I wanted to talk about both short and long term side effects of these drugs that we are aware of.
Yeah. So some of the, and um yeah, no, I see where we're going with this. So like, I guess the very mild side effects that are annoying to have to deal with, but are the most common, is probably nausea and vomiting, particularly with semaglutide. That seem to be less likely with tirzepatide, because of that dual agonist pathway. I have, anecdotally, I know that they had talked about potentially constipation. Um, However, I will say, from my clinical experience and my own personal experience, when you actually start asking people about when people complain about constipation and you start digging into what it is that they're exactly eating, you know, what goes in must come out. So if you're eating, like 3 blueberries and a handful of nuts and you call that like your daily intake, there's a reason, then we have to have a different conversation. And I find that a lot of times, um, there seems to be a disconnect between what people are actually ingesting. When you actually take a look at what it is they're eating on a day-to-day basis, and then looking at, their complaint of constipation, and is it really constipation, or is it just because you're not really eating anything and your fiber intake is pretty low. So those are, some of the more common, very common, annoying things to deal with. Very less common, but something to keep in mind are things like pancreatitis and gallstones. Um, that tends to happen with people. And this is not just a phenomenon that happens just in people who take GLP-1s. It also happens in people in post-op bariatric surgery patients who end up going on a very low calorie, like very low, very restrictive, diet, like 800, 900 calories a day from their previous, diet of whatever it is they're having. Um, so gallstones can form, which can block, the pancreas and then irritate that pancreas. Um, a very, very low likelihood of that happening, but it is a serious side effect that can, you have to go to the hospital. They have to, monitor you. They have to take labs. Um, but also anecdotally, one of my colleagues had mentioned that one of her patients had gone to the hospital for pancreatitis and still joked that the drug was worth it. So, you know, I, I don't make things up. I was just told that. So, again, another point about talking about risk versus benefits. I'm always having that discussion. There is a black box warning on the medication. So people who have a history of medullary thyroid carcinoma, so there's a very specific type of thyroid cancer, or have a family history of multiple endocrine neoplasia, which is also a very specific genetic disorder that affects, multiple different things. They do have a black box warning saying that this drug is contraindicated for people who have that history. However, I will say when you actually take a look at the literature, the risk of thyroid cancer has been shown in rodents, not humans. They actually have not found an association between thyroid cancer and humans who are taking this drug. It's all been demonstrated in rodents. Rodents have the receptor on their thyroid cells, which we do not have. So I think that kind of speaks to sort of the limitations of, you know, extrapolating what happens in mice or some sort of animal model and, automatically, putting that on, interpreting that to this is going to happen in humans. So, but as a precaution, the FDA has, put that black box warning on there just to, um, be extra cautious.
That makes sense, and thank you for clarifying. With regards to the gallstones, as soon as you told me that,
Yeah.
my first thought was, I wonder if these people are on an extremely low-fat diet, because I'm pretty confident you're aware of Dr. Eric Trexler.
Yeah. Yeah.
And
He's
quite
really great.
recently, yes, he is. He's been on the podcast several times as well. But he's recently talked about dietary fat quite a lot because he's been trying
Mhm.
to tease out a specific recommendation from the literature. And what he's found is that the minimal amount of dietary fat we need to prevent gallstones is around 7 grams per day. But if you're having such a strong effect from these drugs that you're not eating, and as you say, your total intake is 2 walnuts per day, well, that ain't
Yeah.
7 grams of fat. So,
Yeah. Yeah.
so that would make sense. Anyway, so there are some side effects, but as you said, some people even find them worth it. And as you brought up, what's important here is to talk with your physician, if you're a patient, about the cost benefit analysis for you.
Yes.
Now, speaking of that, I would like to hear your opinion on who you think is a good candidate for taking these drugs.
Yeah. You know, so I guess let's start with the general population really quickly and then dive into some of the nuances that, we're going to, typically see with in the evidence-based fitness space. Obviously somebody with diabetes, obviously, somebody who, that's just, these drugs are approved for people with diabetes and for weight management. And I feel like yes, lifestyle. Actually, if you look at the algorithm, I will say that with diet treatment of diabetes, lifestyle interventions is actually at the top. I know we forget that, but I just wanted to remind people that, who may think, oh, we're just jumping to drugs and we never talk about interventions. No, 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 no. It's actually at the very top. But because people with diabetes, you have to control it, ASAP. You need to control those blood sugars as soon as possible. Technically, the BMI cutoffs is anybody with a BMI over 30 or a BMI over 27 with some risk factors such as high blood pressure, diabetes, high cholesterol. So that is the technical, kind of definition of, at the very least, what insurance is going to cover. That is a criteria that they're going to go by. What I think, people people who are struggling with their weight, um, people who are at a higher BMI who may have, who have body fat percentages that are a lot higher than, around 30% and higher, um, who seem to who struggle with not just the fat loss part, but also the maintenance part. I think having a good, being able to, I think it's at least, at the very least, worth a conversation. Because, and this is coming from my own bias, from my own experience. Um, it's always been a huge grind. And I just found that, like, there's a lot of people who struggle with the after effects of a fat loss phase, that ravenous hunger that seems to be sort of, that food noise seems to be out of control. So I would, at the very least, kind of, entertain a conversation with somebody who sort of falls in that category. Somebody who, seems to be doing all the right things, but just is still having trouble sort of maintaining a calorie deficit, who, and is unable to even, at some part of that process. I would say, start that conversation earlier than later.
That makes sense. So you mentioned that you wanted to cover general population first
Yeah.
and then cover some more
Yeah.
nuances. One direction in which I think you may take the conversation is the use of these drugs among celebrities that do not fall into this category, but also, as I've heard more recently, well, the usage among physique athletes as well.
Yeah. So my stance with physique athletes is, I don't necessarily, as a physician, I don't necessarily endorse um, the use of performance enhancing drugs. At the same time, I take care of physique athletes in the sense of, I'm going to do everything I can to help make sure that your health you know, um, is on point as possible. So for a physique athlete, I as a physician do not recommend, these medications. However, I totally understand, once these came out, I was very curious to see how, I was expecting that its use in, the bodybuilding space, the physique space is going to blow up. I mean, and why not? Like, it makes sense. It helps people achieve a calorie deficit much easier, that, especially at the end, tail end of contest prep when you're dieted down. I get it. So
Yeah, that makes sense. I was expecting that too. Now I'm just waiting for WADA to ban this from competition, so then non-natural, so that it will only be available in the enhanced world, or maybe they never will, and then it will be a natural medication for people who are not on PEDs too.
So far, WADA for the 2025 list it's on the monitoring list right now. So I know that much. It's not banned yet. I am also waiting for that to happen, and I get it. Like I totally would understand if it, WADA decides to put that, especially with weight classes. So I'm curious to see how that turns out too.
But I agree with you. The usage among physique athletes makes sense. What I'm wondering is your thoughts about the usage among celebrities because they are under the public eye and and especially when they don't need these medications, and in some cases they might abuse them because maybe they're not followed by by anyone. Maybe they're doing it on their own. I wonder about the effect the ripple effect that this could have in people who might take inspiration from that.
Yeah, there was just an article that just got published in the Free Press not too long ago about how celebrities are using it and to achieve a physique that my personally I'm not a huge fan of in the sense of I think that resistance training is the fountain of youth. I think it provides so many benefits, and it makes me really sad when people are scared to do that because they really look up to people who are very um, thin in the sense of low fat, but also lean body mass. Um, so it's always a concern, but I also think on the bright side, I think there's a lot of great people in this, celebrities who are also very athletic, who, we're really showcasing strength. So I don't ever want to, kind of lament on like these very few things that are happening. But when I think of women in fitness, like over the last 20, 30 years or so, like thinking back to like when I was, growing up in the 90s and all this stuff, we women in strength sports and like just celebrating strength has actually increased very noticeably. So I'm actually really happy that social media, there's a lot of great things to take from social media. And so I think, by kind of really promoting and celebrating that, focusing on that versus, kind of these kind of celebrities are doing whatever. I just try and focus on, making sure my voice is heard or I celebrate, the accomplishments of other really awesome females in the space, if that makes sense.
It does, and that's exactly why I'm recording this podcast so that we can provide a more critical review of these drugs so that people can take from this and then they can take from social media what best serves them. So my next question would be, are GLP-1 a short or a long-term strategy? And if they can be both, then what are the circumstances when you would consider it worth it to stay on the drugs, almost like you would stay on levothyroxine for life, essentially, if that's even possible, versus taking it only short term?
Yeah, levothyroxine is yeah, if you continue to have low thyroid activity, levothyroxine for life, no big deal. These drugs are meant as a long-term solution. The food noise or the hunger signaling may or may not go away. I think the jury is still out. I know that they have done studies where people have like been on the medication, stopped the medication, kind of track to see what happens. Um, a good amount of people, a majority of people lost or gained some of the weight back. That being said, I've seen both instances where people are still on the medication and are doing fine, living their best life, maintaining a very healthy weight. But I also see some people who are very interested in coming off of the drug for whatever reason. And I find that most of the people who want to come off the drug are usually the patient who is asking. And I usually try and ask, like, for what reason, or just to get a sense of like where their head is at. Some people just don't want to do the injections for once a week. It's really annoying. It hurts. Some people want to see if they can do it, like and I support, and I, as a physician, I support that. So some people have managed to stay off, keep the weight off with coming off of the drug. Some people reduce their medication to a very low amount and come off. So it's still, I don't have a clear sense of like, oh, if these set of circumstances, like you should come off the drug. My sort of approach is, let's just stay on the drug, see how you're feeling. These are very safe. We've been using these medications for a very long time now. And then continuing to check in and have that, constant rapport of like, how are you doing? And kind of let the patient kind of decide where they want to go with that, if that makes sense.
It does. Thank you for explaining. Now, what you refer to injections just now, this reminded me that earlier you referred to um, the oral tab version
Mhm.
of semaglutide, which is called Rybelsus, I think, or Rybelsus. And so, what that brought up for me was a question about efficacy. Do we know if the oral tabs have the same efficacy, or if the injections are the most efficacious way to use the drug?
The medications or the injections are definitely a little bit more efficacious. So the Ribelsis, you have to take it daily. I think you have to take it 30 minutes before your first meal. I think you have to take it with a large glass of water. So and it's a daily thing, and it's also a chore. It's also like levothyroxine, where you do have to take it first thing in the morning, before anything else. Like you have to be mindful of, and because it's an oral pill, you have to be mindful of what other medications is the patient taking, what other supplements is the patient taking, because people forget that supplements are also have interactions. Um, so the injection sort of bypasses the first effect, having to avoid going through the liver, getting processed. So, and it's once a week.
That makes sense. A follow-up question on efficacy was also back to when we were talking about, okay, most people may have a 5% weight loss almost as a guarantee, up to 20%. You also mentioned that the results are dose dependent.
Mhm.
Are they also, is there a spectrum of responders, like for creatine, where there are non-responders all the way up to hyper responders? Or does everybody respond pretty much the same?
There is seems to be a bit of a kind of range of responsiveness. I've seen people who don't really respond at all, and I've seen people who kind of respond to like doses, the baby dose that people are expected to take when just for the first 4 weeks, just to get just to get used to like the side effects. So I've already seen a wide range of effectiveness, and then people end up going on tirzepatide and seeming to have an effect. I haven't. I have anecdotally seen a couple of small handful of people who don't have a response at all. Um, so and for those people, it's an unfortunate reality of, medication. Not everybody's different.
Thank you. I thought it was important to cover that as well. Now, you've already mentioned resistance training being the fountain of youth, in your opinion, the importance of lifestyle strategies to go along with the use of this medication. What specific lifestyle strategies with regards to nutrition and movement would you recommend implementing to get the best effects in terms of fat loss, well being, and fat loss maintenance?
Yeah, the I mean, if you really wanted to get, the best bang for your buck, if you are somebody who, resistance trains 3 to 4 times a week, and that's like an already an established habit that you have. If you're somebody that eats, cooks majority of your food, or gets, a very trusted meal prep service, where the majority of your meals are consistent, at the very least have, mostly comprised of protein, has some sort of fiber, in it, and then whatever carb, kind of complex carb in there as well. Um, if you're somebody who cooks regularly, has consistent meals, and goes to the gym 3 to 4 times a week to do some resistance training, hypertrophy style training, to get the most muscle mass, a bang for your buck muscle mass in the gym, I would say that's, you're pretty set, you're pretty good to go. For a lot of people, sometimes that just doesn't happen. So even, I would say even people who go to the gym 1 to 2 times a week, it really depends on where people are at and kind of going from there. I mean, I have people who have success going to the gym 1 to 2 times a week, and then, learning how to sort of meal prep and not having everything there. If you get like 80% of it right, you're good to go. So, just because you're not, I also just want to make the point, because I do know that there are people who kind of see what I'm doing, in social media as a recreational athlete, and thinking, oh, I've got to do that. No, you don't have to. Like, we can, you don't have to be like some jujitsu person and some person who's like in the gym 5 to 6 days a week, to get those type, the same types of results, to get whatever it is, your definition of success.
That's excellent. Thank you for clarifying that so that it paints a much more realistic picture of what can be achieved with a little bit of a lifestyle change. You don't need to become an Olympic athlete to make the most of these drugs.
Right. Right.
I'm wondering if there's any supplements that you are aware of that could be beneficial versus that one should stay away from if using these drugs.
I would say, like, you mentioned creatine. I think creatine is, super beneficial. It's been studied into the ground. So it's safe, it's effective. Some people may not respond. I think the biggest thing that people need to keep in mind is alcohol, and also high fat foods, especially all in one kind of, together, because I know that with alcohol, a lot of times, the fried, fatty, high fat foods kind of come hand in hand. I would be very careful of that. Just because, your digestion's slowing down. A lot of people I find, anecdotally, just don't seem to be interested in smoking cigarettes. They anecdotally don't seem to be as interested in alcohol as they once were before. If they do drink alcohol, the tolerance kind of decreases quite a bit. Um, and I think also with lifestyle changes over time, that also tends to, what happens is people stop drinking. So then their tolerance decreases. But is it really the medication, or is it a combination of their lifestyle changes plus the medication, or some semblance of both? Um, and then the high fat foods, people can, find themselves feeling really sick, and not feeling so great, with that slowed down digestion. So I would just be careful of, mindful when you're at the bar or out with your drinking with friends and you're on this medication, to just be very careful about your alcohol intake.
Okay, thank you for explaining that. Now, I was also thinking back to something else you said earlier in the conversation when you made that point about diet fatigue. Potentially, what role does that play in the experience of people in these studies? And what that brought up for me now, half an hour later, is a question about the fact that some people report different side effects than what you've described. Like they mentioned being extremely fatigued, like you mentioned that patient of yours was saying. And so I think it might be helpful to differentiate between what might be caused by diet fatigue from you having been in a steep calorie deficit for a long time versus what is an actual proven side effect of the medication.
I'm sorry, you kind of cut out just a little bit. So you wanted me to
Oh, I did.
differentiate between, kind of diet fatigue versus like a side effect of the medication?
Yes, because the way I'm looking at this is if I heard anecdotally some people report side effects like fatigue and tiredness,
Mhm.
somebody who isn't really in the fitness space and may not know as much may think that this is a side effect of the drug, whereas I and you also seem to have wondered, might it be a side effect of just being in a calorie deficit for a really long time? So I think it would be helpful to bring up some common side effects of being in a deficit for that prolonged period of time and losing so much fat so that people know
Oh,
that one symptom might be a sign of diet fatigue versus another being an actual side effect of a semaglutide or another weight loss drug. Does that make more sense now?
right, right. So, the other things, thinking about just diet fatigue in general, not just the exhaustion, things that I've also noticed with being in a prolonged calorie deficit is, how often are you getting sick? Like, are you getting very frequent colds? I remember very early on in my like childhood, whenever I would diet, um, my hands would turn cold. I'd be exhausted all the time. And then I would get actually sick quite often. So that's also another thing, keep in mind. Really lack of sleep. Like, do you find yourself, and the way I ask it is, do you find yourself like waking up in the morning and just feeling really antsy? Because that cortisol dump after, the end of a prep, hard fat loss phase can really be really, sort of intense. Irritability. How are you like, how are your relationships? Do you find yourself, kind of a little bit more snappy, or how are you handling, stuff going on at work? Um, and then for people who do go to the gym, like, are you able to make it to the gym? Do you feel like, I just don't want to be like, desire to train is also one. Like, do you even want to go to the gym? Are you able to get through your sets? Taking a look at injuries. When people are super fatigued and they push themselves, sometimes they do end up finding themselves, doing something, at the gym and finding themselves injured. So, um, sometimes I do ask about, menstrual for females. I do ask about menstruation. However, I find that a lot of people in the United States have birth control methods that kind of, I always ask about it, but I find that they have, birth control methods that make that kind of question sort of a non-starter. So a lot of people have hormonal IUDs in place, so they don't have any periods. So that's just what it is. I know in other countries, like, a lot of people place really huge emphasis on, like, you have to have your menstrual period, and it's like, well, you know, sorry, there's a IUD preventing that in there. So I place less emphasis on the whole menstruation thing, but in general, because I just don't work with that. I don't end up seeing a lot of people who are at least, or who are not on hormonal birth control and who are tracking their periods.
That makes sense. It's quite common here in the UK as well, to be fair. But I think this was a really helpful list of symptoms because I want to state clearly that I do not know if you could get these symptoms from weight loss drugs as well. But if there is an anecdotal report of these symptoms, and or it's even reported in studies, but there isn't a differentiation between whether the symptoms came from the diet fatigue or from the drug, we can't be sure.
Yeah, no, there is no study that has actually differentiated that. And I think it's going to be hard to do that when you have a drug that allows somebody to be in a calorie deficit that much easier than if they were off the drug. So, you know, um, and I mean, I guess I will say, as somebody who is personally on this medication, I've experienced both symptoms of diet fatigue, both on and off the drug. So N equals one. That's not a study, but just my own, kind of personal anecdote there.
What I get from that is that if I were somebody who's listening to this and doesn't know much about these drugs, I would think, okay, so the good news is that these side effects are not exclusive to the drugs. So if I were worried that that could be the case, no, probably not. I might experience them regardless. But also, what's interesting is that the drugs don't seem to resolve them. So that is something to take into account, whereby, yes, it's easier to be in a calorie deficit. It doesn't mean that the experience of the entire diet is just easy peasy now.
Oh yes, I think I was on the Steve Hall's podcast, and I think he had asked me if I like had any desire to like lose more weight or see how I can push myself, my physique, anymore. And I was just flat out no way, because again, like you had just said, um, yes, I'm not hungry, or my hunger is taken down to a 2 out of 10, but it definitely does not get rid of the other markers of diet fatigue. And also, I really value my work. My work is more important than my physique, at least, for me. And so, yeah, the trade-offs just aren't worth it for me. Like, I like, this is a good spot where I'm at right now.
I think that's an excellent way to end the podcast because I am really curious to hear a little bit more about your own personal experience, about your relationship with food and your physique, and what made you come to the decision to start using these weight loss drugs? And now that you've been taking them for a little bit of time, what's your experience, and how do you think you will continue to engage with them, if at all?
Yeah, very long history with weight loss, even spanning as a child. I was always hungry. I was always, I always felt about 20 pounds heavier than my, peers at school. Um, you know, the always sneaking in food. I was active. I played sports, but like, the dieting thing, I think went on my first diet, the self-prescribed diet at like the age of 12. Um, trying to like some combination of like healthy versus some not so healthy habits that I had picked up. I did lots of cardio. I didn't do any resistance training until like my late 20s when I picked up powerlifting. um I had dieted myself. I had dieted for over a year. Went down from 150 to 130. um and the food noise was so terrible. My first year into medical school, I would toss and turn um throughout the night. I would get no sleep because I was just so hungry. I could feel like it felt like my stomach was eating itself, and I was like, yep, this is just what it takes to, and I was not anything special. I was not super skinny. I was not a super skinny celebrity. I was not like a lean or jacked bodybuilder. I'd actually lost quite a bit of muscle. I just looked kind of small, ish. Send you a picture. It was just not, looking back, it was just not really anything spectacular. Um, spent a
Sorry,
lot of
sorry
time.
to
I'm sorry.
interrupt.
Yeah,
Just to put things in perspective, what you went from 150 to 130. How tall are you?
I'm 4'11".
Okay, because that helps people understand.
Yes.
Because 130,
No.
somebody who's like 5'7", is a very different look.
Right, right. I've been as heavy as 200 pounds, and right now I'm at 140 pounds. So usually my range at 4'11" has always been somewhere along those lines. Um, it wasn't. I had been on weight loss medications before that were not GLP-1 agonists, and I had failed them for a bunch of different reasons, side effects, whatnot. um, my doctor actually recommended Wegovy very early on in the COVID pandemic, and I said no because one, I was just too stressed out from COVID, and I wanted to finish my fellowship, and two, I just felt like, I don't know, for whatever reason, I just had a really big ego. Like, why can't I just do this on my own? Even though every single time I've essentially failed at maintenance. I failed to maintain every fat loss phase I did. It would just be a uphill battle, and the weight would just climb back up. And Mike had tried to even create an RP product called the Evening Hunger Templates to kind of, help with that, because he hadn't seen anything like that before. So I was eating like 3 cups of broccoli and some clean, some chicken breast, and like my stomach would be like distended. My stomach would hurt, but I'm still hungry. I'm like ravenously hungry. So that failed. And so I guess it wasn't until I saw him at the tail end of contest prep with how much food focus he had had. And, I just sort of kind of came to the kind of slow realization that, what, maybe some of us just have a food focus that's way, our scale of food focus is way much different than compared to like a natural bodybuilder who can seemingly diet down very easily, seemingly maintain some weight, and like it's all good. Maybe I'm just here and I just need a little bit of medication to help bring that level of food noise down. So I started my medication. I started semaglutide in January of 2022, and I remember it felt like a light bulb had gone off in my head. And I remember like eating and thinking, this is what a thin person feels like. This is the weirdest experience I've ever had. I remember going to San Diego with Mike, and we were out to dinner, and like I had maybe a half a glass of wine, and I had like, we shared an appetizer. I had a very lean steak. I had some broccoli on the side. I had most of it, but I left a couple bites on the plate, and I just remember kind of looking at him and kind of looking at the food and just enjoying the conversation that I'm even having with him, because prior to that it would just be like, I am not listening to you, I just want my food. Like, I'm trying to pretend like I'm not hungry but I'm starving. Why am I like this? Why am I broke? Like, why is my brain broken? And just really beating myself up for a number of years, thinking that, like, I don't know, like, maybe if I just, do all these other things, maybe if I just accomplish myself in all these other fields, like, I can make up for the fact that, like, I'm just hungry all the time, and no amount of eating, drinking water, being mindful, praying, like, taking 30 bites per meal is gonna, like, satisfy this, like, gnawing, like, rage that I have in me to, like, eat. Like, and I would love to, like, try and just explain that to people. Like, it's not like I don't have any, like, trauma that I'm eating from. It's like, it is this, like, just this drive that, like, I can't explain to, how, like, instinctual it is, at least within me. And it wasn't until I got on medication that I'm like, oh, I can have a reasonable plate of food and be at peace with what's in front of me.
Thank you
I
so
hope that
much for
helps.
sharing that.
No, sorry. Just I just yeah, no, it's when I say that, it has the ability to really transform people's lives, it felt like, yeah, that light bulb going off in my head was just, it had been like the answer I had been looking for so long. And just I can't describe to you um how the amount of emotion and feelings I had being this sort of peripheral person in the fitness space, and sort of watching people, kind of give recommendations of, like, just eat mindfully, chew slowly. When you have this, like, monster on your back, just like, you want to eat that, you want to eat that, look up food. Oh my God, that tastes so good. And I wish and the when somebody's like, oh yeah, you had no willpower. I had willpower back in 2012, and I couldn't sleep. I failed my anatomy class in med school, and it got me nowhere. So you know, so these drugs do have an ability to really transform lives. However, it's not just a magic solution for everybody. You do have to put in the work.
I am so happy that we were able to cover your personal story because I think it will really resonate with a lot of people in a similar situation who are on a similar part of the hunger spectrum, so to speak. And it will also offer some reassurance, I think, that they're not alone and that they are not failing at willpower. Because one message that I have seen in the space by some people is that taking these drugs is cheating, that with willpower everybody can do it, when obesity is categorized as a disease for a reason. So why couldn't an exaggerated hunger response not be a symptom of that, when we do know that people who have obesity also often have hunger dysregulation? Might it be brought on by the obesity itself, or could it be that that is a contributing factor to the obesity?
Yeah. And I came out, I was a C-section baby. I came out, like, I think 8.5 pounds. I came out a big child. So, you know, uh, that wasn't my fault. So, I also understand that, like, once you get to a certain weight, those fat cells will multiply. They don't go away. Like, once you lose the weight, I still have the same amount of fat cells as I did at 200 pounds. So, and those are active cells, like, sending out signals, to the rest of my body. So it is what it is.
And I am really happy for you that you found these drugs to be so life changing for you, and that you can now be here and tell your story and be able to be present in the conversation because your stomach isn't eating itself.
Yeah. Yeah. No, I love the fact that I can go to sleep at night and have a full night's rest.
I bet. So, Crystal, I want to be super respectful of your time. I have asked you everything that I would have wanted to know, and I hope that the listeners will get a lot out of this. I know they will, if they listen until the end, that is. I want to thank you again for coming on the podcast, and I'd like you to tell the listeners how they can connect with you if they'd like to follow your work.
Oh, yes. So I'm on Instagram. It's dr.christle, Christle.
Excellent. I will put a link to your account in the show notes. Once again, thank you for coming on the show today, dear listeners. Thank you for tuning in, as always, and I will talk to you next time.
Lastly, if you want to support the podcast and help me reach more people, please leave a 5-star rating or review on any podcast platform that you're using. Thank you very much for listening, and I'll speak to you soon.